Hi, it's Dr. Fox, and I was just going to do a quick intro to this video. This video was actually an interview that I did with a DBT group in Poland, and it was very cool. And I think that what we did is we went over kind of what's going on in BPD, what are some of those main concerns, what is BPD, what are some myths and facts about BPD, which is always important to put out there. Also, one of those important things to remember, we also talked about comorbid disorders, management, treatment, also, the BPD domains and treatment areas. So please stick around and check it out. I hope you enjoy it. Take care and bye-bye.
Dr. Daniel Fox is a licensed psychologist, yes, international speaker, multiple award-winning author, from what I learned. He's been specializing in the treatment of personality disorders for over 20 years, if I understand correctly, in private practice, at university, and also in prison system, yes, in federal prison.
Yeah.
And he's the author of the book that recently was published in Poland. I have it somewhere here, but I lost it for a second, which is absolutely great. So I know that you prepared something for us today, but just before, can you tell us what was the impulse to write this book? Because from what I've read it twice, once in Polish and once in English.
Oh, great.
Yeah. And it's wonderful, and I use it a lot in my practice. But it's fantastic because it combines a lot of systems, I would say. So it's DBT, but it's not DBT. It's CBT, but it's not CBT. It's chemotherapy, but it's not. So how do you combine all of that in one book?
So what I did is, so I'm asked multiple times throughout the year, to provide therapy, to provide treatment and things like that to various folks in different parts of the world. And I was never able to accommodate everyone. And whether it could be a financial issue or it could be just a time issue, whatever it may be. And so what I wanted to do is sort of write my system down to try to help folks, as well as, not just those that are diagnosed with BPD or those that have BPD traits, but those mental health providers that also provide services to those individuals. So I wanted to try to create something that basically followed my approach, which was, first identifying, is BPD there? To what degree? Then working on what I call surface structure, which is a lot of those depression, the anxiety, those other comorbid types of conditions, but also those, beliefs, behaviors, and patterns that come out of that core content of BPD, and then getting to the heart of BPD. What is the central components? What are the most challenging issues of BPD? And with my clients that I work with, we worked together for years just trying to not only get at core content, but also change it. And then when we do that, what type of stabilization mechanisms or approaches do I utilize with my clients that have been affected? So that was sort of my approach to it. And I pull from all of these different theories and modalities what is most efficient for the client, because, we're all trying to make things as efficient and not necessarily compartmentalize, but manage all of these things, because we all have, other things to do, right? We all have other parts of our life that we need to continue to go forward. So that was the impetus. That's why I pull from all of these different theories. I kind of pulled together over the years these different components that seem to fit, that some clients, even now, I still sort of try out different approaches with different clients and different sort of mechanisms, or not necessarily sort of, what's the word I'm looking for? Not necessarily translations, right? Because I don't know if that'll come across well, but sort of interpretations, different components that we can utilize that helps them not only gain insight, but then to use that insight for behavior change. So that was the big impetus.
Yeah, it's just great. It's like Fox treatment, yes? Something.
Yeah, there you go. Maybe that'll be a thing. We don't know.
So thank you for writing it for us. It's really helpful. Okay, and you prepared something for us. So now I'm all ears.
Oh.
And yeah, I will listen carefully to what you say.
Oh, okay. Oh, wow. So what I did is, so I wanted to do just a short presentation about not only what BPD is, but also some of the myths, some of the facts, as well as like the 4 underlining components. And then, you know, sort of that main conceptualization of what BPD is, which I think a lot of folks do misunderstand that. And that is just this one sort of phrase that that I'm just going to sort of put into context eventually. So I'll kind of say that as we get closer to the end of this sort of presentation component. And then, you know, certainly if you have questions or people have other questions, I'm happy to answer those or whatever I can do. I'm very passionate about doing talks like this because I think it's so important, particularly as it relates to BPD, because it is so misunderstood.
Yes.
And, you know, so but before I kind of get into the formal stuff, so I was just talking with a student yesterday. So I also supervise doctoral students as well. So I was talking to one of my students yesterday, and we were talking about that she had given the diagnosis of BPD to someone. And we talked about, okay, so if you give it to someone, you know, what were the components of that? First of all, there wasn't enough history in order to fully qualify for the full diagnosis, right? Because we want to make sure that it is over a prolonged period of time. It's not just something that just occurred out of a traumatic brain injury. Absolutely not, right? We want to make sure that it's not something out of a divorce. It's not something out of just trauma, something like that. And it was hard to get that history. So we couldn't really say that it was BPD, even though prior to the traumatic brain injury, there were a lot of indicators there, but we couldn't go back far enough in order to really clarify it. So as we were discussing this, her and I said, you know, what I added to that, I added a rule out. And that rule out, I think, is really important, particularly, you know, for mental health providers, is that, you know, we have to see that rule out. We have to see that those are traits, because most people are going to qualify for traits and not for full disorder. And that's a big difference, not only as it relates to prognosis, but also all of those other belief, behaviors, and patterns and their intractability, how difficult those can be to change. So as her and I were discussing this, you know, you could kind of see, and this is why I like working with students so much, because I think there's so much value in it, because she will someday be, you know, a psychologist. She will someday, you know, be treating individuals that will likely have personality disorder traits. I mean, all over the world, we're having a massive increase in personality disorder traits, not just BPD, narcissism, you know, histrionics, antisocial, and antisocial just isn't in the US, it's all over the world, right? But also cluster A's and cluster C too. So we're seeing this rise in personality components. But to get to the presentation, what I first wanted to do is really sort of describe my conceptualization of what BPD is. So I'm asked that a lot. So how would I describe BPD and what is it? So the way that I like to describe it is that BPD is a combination of genetics and environment that make it hard to feel love, and even harder when you feel rejected. So it's a constant search for connection when you don't know what the connection is. It's a sense of loneliness and fear without knowing exactly where it comes from or where you're going with it. The tidal wave of thoughts, emotions, beliefs, and memories that evoke this self-destructive means to try and resolve or calm that tidal wave without having the skills to necessarily do so. Now, over time, this becomes very cyclical and it becomes habitual. And this comes out of something we don't fully understand, but it disrupts emotional, behavioral, interpersonal, as well as identity aspects of life. So this is a complex disorder, but it is treatable. And hope should be in the forefront as individuals kind of seek and engage treatment to outgrow, to grow beyond all the things you once believed you couldn't. And that's kind of my conceptualization of what BPD is that it's not just behavioral. There's often a confusion that people think it's a choice, that such and such is acting this way because they want to. You know, I've never had a client ever say to me, you know, I really want to destroy my life and the life of everybody that's in my interpersonal circle as best that I can. I've never had anybody do that. Now, I've worked with some antisocial folks who may say that, but they're not BPD. They don't fall into that BPD category. But there's that misconception. There's that application of this volitional stance or intent to purposely just destroy their life. And if you look at the research, if you look at those that are effectively managing BPD, things like that, that it is learning coping strategies, it is learning management strategies, it is learning interpersonal interaction, but also a degree of self-control. So if we look at that, then is BPD just this really complex maladaptive coping strategy? And if you look at it that way, then I think we see it in a much more treatable manner, right? If it's a maladaptive coping strategy, can we change it and replace it with something that's adaptive? And we absolutely can't. I mean, there's so much data on success with folks with BPD, but people forget that because the stigma from the 70s is still hanging on. And that stigma is, right, that these folks are untreatable. And that kind of goes into those myths, right? It goes into those myths and the lack of facts and things like that. And so just some of these myths are held by mental health providers. And interestingly enough, so when I do seminars, and I, before COVID, I would kind of travel, to different parts of the world and stuff to do these presentations. So many of the mental health providers would sort of espouse these myths that they believe to be inherent truths. And that's one of the things that really motivates me to kind of work with these folks and also, dispel a lot of these myths, because the research doesn't support it, but sort of this wedded belief that these people are all destructive, that they're all going to stalk you, that they're all going to blow up your email and blow up your phone, and they're going to be in and out of inpatient and all this other stuff. And it doesn't necessarily, it's not like that with everyone. And one of the first things that I say to those mental health providers is that we can't look at 97% of the individuals who have this disorder as the upper 3%. And that's what happens. The upper 3% are those extreme cases. They're exceptionally rare, right? They're 3% at a time. But that upper 3%, those are the ones that are blowing up your email, blowing up your phone, that are in and out of inpatient, that are switching therapists all the time, that are really, really struggling to get through. But that's the 3%. Majority of folks is the 97%. And what's interesting is if we look at that normal curve, and that normal curve, the meaty part of that curve, like that big part, where you got that big hump and stuff, those folks, most people don't even recognize that it's BPD. Most mental health providers don't even recognize that those are BPD traits, that those are these stable, prolonged patterns that these individuals show, because they get better in treatment. So they don't even fall into the category of BPD, because the therapist, mental health provider, or even the client themselves doesn't consider it, because they're like, well, I mean, I only have, 3 of the 9 traits, 4 of the 9 traits. Right. Those are the traits. You don't have the full disorder, but you qualify for traits, but it doesn't count. So that doesn't get considered by many of the practitioners. So we miss the mark. So we want to kind of stay focused. So I've got 7 myths or facts, and then I'm going to go into just straight facts. So the first one is, so BPD patients, that they try to defeat their therapist. And this is an absolute falsity, right? That these are people who are going, and it's so contradictory, that these are folks that are coming to treatment to just destroy treatment. It doesn't make any sense. Now, there are people who come to treatment, those with BPD and without, who come to treatment because they're not quite sure as to what they're doing. They're not quite sure as to what's going on inside them. They're not quite sure why they're responding this way. And the universal criteria across all personality disorders is impaired insight. So if we know that impaired insight is universal, we shouldn't be surprised that some folks are going to come to see us and say, I don't know why I'm doing the things that I'm doing. I don't understand what's happening, why I have these intense action urges to respond, and they want understanding. So if we look at it from sort of the stages of change model, right, we can look at, pre-contemplation, no one's really coming to see us, right, because they don't think there's a problem. But you look at contemplation, or even, preparation, then you're kind of like, wait, so something's not right, something doesn't fit. These are folks that may not be in treatment for the long haul, but most therapists don't assess where an individual is along the stages of change. So what happens is you develop this myth that these individuals with BPD are out to defeat their therapist. That's a complete myth and a fallacy. Most individuals with BPD are treatment seekers, not only for self-understanding, but also to learn adaptive strategies so they're not so destructive, so they're not engaging in these destructive beliefs, behaviors, and patterns that continue to disrupt their relationships and their lives. And so the second one, this is patients with BPD do not improve. And this goes to that massive fallacy that they fall into this category of the untreatable. And the research does not support that. Many of my colleagues, recognize that this is not true. Those who have actually worked with individuals with BPD or BPD traits recognize that this isn't true. The problem is this stigma has become so universal, it's become so spread out that clients themselves has internalized the idea, that they internalize this idea that, oh yeah, well, so I'm not treatable, so then, and with another myth that I'll talk about just a moment ago, but this is sort of paired with this one, which is that BPD is a death sentence, right? That once you get it, you're never going to get rid of it, and eventually, your whole life will dissolve, and there'll be nothing that you can do about it. And that's a complete fallacy. What kind of got me into doing this and the YouTube channel that I have and things like that is to inspire hope, genuine hope in individuals with BPD. So folks can recognize that this is a treatable condition. It is a manageable condition, and it is something that people can learn to control over time. But the stigma is the hardest thing to manage, and particularly in those who have BPD traits, and particularly in those that have BPD. They have to understand that this is treatable. You have to hang on to that degree of hope. Just like in my explanation of what BPD is, that it's something that we have to understand that you can get over. It's something that is treatable. Now recognize that I didn't say easy at all. And all of my clients understand that. Treatment is usually years, not months, depending on the severity of the BPD, the degree of the intractability, initial intractability of those beliefs, behaviors, and patterns, that it takes time. These things take time. So it takes time to learn adaptive skills over maladaptive skills. So it's part of that process. It's not going to be right away, and there's no pill for it either. Wouldn't that be great? Like if there was a pill for personality, right? I mean, wouldn't we all give it to our spouse or our boss at periods, right? Just kind of sprinkle it in their coffee or something. Sure. Well, I mean, of course, right? We would all do that. But the reality is that we can't, right? Because there isn't. So, and we'll get to that in a moment. Another myth is an unlikable person must have BPD. And I'll tell you, some of the most fascinating and interesting people that I've ever met are on that BPD spectrum, because they're often exceptionally creative, highly motivated, as far as they may have a lot of serial employment, which is, like you'll work somewhere for like a year or two or a few months and go on to the next one to the next. Now, there are some who do get into work environments and they are arguing with their boss, right? They are arguing with customers. They are arguing, and there are folks that are very self-destructive in sort of an economic way, right? But that would increase that prognosis. That would increase the severity of the disorder. But to say that all of them fall into that category, that those, everybody with BPD is unlikable, they're these harsh and aggressive people, this just is a fallacy. It's just not true. Another one is, so you can't say BPD diagnosis to a client or to a colleague. And that's, this is like, so when I first got into doing this, right, before the internet and stuff like that, there wasn't, you know, the DSM criteria online, and there wasn't all this, you know, all these little things, you know, oh, do you have BPD? And then you can fill out, you know, all these little questionnaires and stuff. I do caution people about doing that. You know, you got to be really careful about doing that, because just filling out that questionnaire, there's more to it than just the 9 criteria in the DSM, which is why it should always be a trained professional who gives the diagnosis, not some website that just gives you criteria. And, you know, now some of those things can be interesting, can provide a degree of insight where you're like, oh, that's interesting, and that may be an impetus to go talk to somebody, but the diagnosis itself shouldn't be derived just from, you know, a little questionnaire online or something like that. But the BPD diagnosis, you know, people don't come to me anymore and say, you know, oh, you know, I'm not sure what's going on, I'm not sure what I have. People lately, probably in the last decade or so, they come to me and they say, well, I think I have BPD. My follow-up question to that is, what makes you think that? And they say, well, I read about it online, I think I have that. And that sometimes can open the door to processing it. But I think that we should be open and honest about the diagnosis. If clients want to discuss what it means, I think that that's fine. And I think, you know, discussing what that can mean, you know, for family members and loved ones and even coworkers, or managing, you know, their life and different facets of their life. Next one is, so comorbid disorders can be treated effectively without treating BPD. Now, this is one that I really want to focus on. So, and I just want to say it again, is that comorbid disorders, now that would be depression, anxiety, PTSD, complex PTSD, psychosis, ADHD. These are those other conditions that tend to occur with BPD. So the myth is that comorbid disorders can be treated effectively without treating BPD. And so my next book that comes out the latter part of this year and in January of next year is what I'm calling complex BPD. And this complex BPD is the recognition that there's pure BPD and complex BPD. Pure BPD is that there's only BPD, that individual does not qualify for any comorbid conditions, right? So that means that there's no major depressive disorder, there's no generalized anxiety disorder, there's no PTSD, there's no complex PTSD, there's no ADHD, there's no psychosis, you know, things like that. But the reality is that about 97% of individuals are going to have what I'm calling complex BPD. This is that you have BPD with comorbid conditions. And based upon what those other disorders or conditions are, should guide treatment. For example, bipolar disorder. So about 25% of individuals with bipolar disorder will also qualify for BPD. So if that's the case, then we as mental health providers, but the individuals themselves, need to recognize that medication is going to be critical, because what it's going to do, it's going to help control those manic and those depressive episodes. If we're not controlling the manic and depressive episodes, how do you know if it's from BPD activation or it's episodic related to bipolar disorder? You don't. And that becomes problematic. So that's why first, in that case, we need to get the bipolar disorder stabilized so that then we can start working on BPD stuff. Let's also use the example of major depressive disorder. Major depressive disorder, a lot of times you have to treat the BPD first before you can actually work on the major depressive disorder. But everyone, or typically most, that have BPD also have what are called depressive episodes. Depressive episodes are not major depressive episodes. Depressive episodes are that, you know, you kind of slide down to this low-level degree of depression. Now, the severity of it may vary by the individual, but so you're still going to see that, but it's not going to go to that severe level of major depressive disorder. So we have to learn to manage that. We have to identify it first. Then we have to learn to treat it, and we have to recognize that over the course of time, utilizing strategies to work with BPD will impact the major depressive disorder. But if we try to treat the major depressive disorder first and say, well, that will help resolve the BPD issues, that's not going to happen, because you're going to continue to have these depressive episodes that are not major depressive episodes. And if that's confusing, it's confusing for everybody. And that was sort of the impetus of me writing this book is so that people can have a greater understanding of those comorbid conditions, when we should treat BPD first, when we should treat the comorbid conditions first. So I'm really excited about this. I just sent the manuscript to my publisher, so I'm really excited. I like that. That's my favorite part. When I'm done, I can kind of send it off to them. So that's always a big win for me. I like that, because then I can move on to other stuff. I like to do other stuff, but also in the same vein, because I think this is really important for the field as well as for individuals who have BPD to understand this component that I'm calling complex BPD. The other myth is the diagnosis cannot be made before 18 years of age. This is kind of a slippery slope, because so it depends. Now, anyone under the age of 16, in my professional opinion, we should not be diagnosing with a personality disorder. And at 16 to 18, within that area, that gets a little nebulous. It gets a little cloudy, because it can't be just the presentation of these symptoms, because most teenagers at one time or another would then qualify for BPD, right? As teenagers, people are more reactionary. As teenagers, people tend to be more angry. As teenagers, particularly young girls, and the research supports this is where I'm getting this, is that more young girls are cutting themselves, more young girls are engaging in self-harm, more young girls are having this really adverse impact on their sense of self-concept and their self-esteem. And a lot of that is due to Instagram. A lot of that is due to social media, because they want to, their self-esteem is built on likes, on the little heart thing, and all that. So what happens is you have this constant external need for validation on who you are and how you're perceived. And what happens is girls, they manage this, very poorly, particularly as teenagers. Most teenagers handle things poorly. That doesn't mean that you have BPD. Now, in 16 to 18, right, that little window, if these instances occur for at least 12 months, which is a long enough time to see that it is a pattern, it is a prolonged pattern, then we could give the diagnosis of BPD. However, even between 16 and 18, I still consider it provisional. And that is because as individuals matriculate, as they get older, then a lot of times they develop these coping strategies. So if BPD is a sophisticated maladaptive coping strategy, a lot of the teenagers, a lot of these folks, 16 to 18 window, they develop these coping strategies, which then brings me to another component, is that once BPD isn't always BPD. So with my clients, every 2 years, we do a reassessment. So we should always be going back and taking a look at what symptoms are still present, what comorbid conditions are still present, what core content issues are still present. So, and it's so important to take a look at that, because what I find over time, we need metrics, and it's so important. With my clients, I'm always on the lookout for these depressive episodes, not major depressive episodes, but the depressive episodes that come along with BPD. And how long is that individual in that depressive episode? So a lot of times, a lot of my clients, as we go along, those depressive episodes start to get shorter. Initially, when we start out, sometimes they're weeks. Now, weeks would qualify for a major depressive episode as long as those other factors are in there. Okay? But let's say that those other factors are in there, so it doesn't qualify for a major depressive episode, just to make it simpler. So if we're just talking about those depressive episodes, then how long are they lasting? And as we're working together, what I have found is that they start to get shorter. And eventually, over time, they may be hours, whereas before they were days. Imagine the success in that. Imagine that person recognizing that, yeah, you know what, I used to get this hit of depression and it would wipe me out for days. But now I've learned these strategies. I've learned that I can push back on this. And now those depressive episodes, yeah, they're going to hit you, but all of us get sad. All of us get down. All of us get frustrated, but we don't let it, destroy our whole day, destroy our whole perception of self, destroy, our relationships and our employment stability and things like that. So, but imagine if it can just go to hours or just 1 hour. How is that not an amazing success? And over time, I see that in my clients. So we need to be doing these reassessments. We need to keep going in and looking, and that is so important. So, and just to sort of tie this together is that, you know, that little window of 16 to 18, you know, we really need to be cautious and careful. People do contact me and say, oh, my 13-year-old has BPD. Yeah, there's no way I'm giving a 13-year-old BPD. There's just no way. I would never do that. And I think sometimes they're reading it online and then things like that. Because when I follow up with those folks, I'm like, where did the diagnosis come from? They're like, oh, well, I read it online. Okay, well, that's not really a diagnosis. That means you think that they have the trait. But, you know, then we sort of have to look at that. And again, but at 13, I would never give a 13-year-old BPD. I wouldn't do that. So what are some facts, just real quick, and then we can open it to some questions. So BPD is environmentally induced. That is absolutely not true. It is a combination of genetics as well as environmental reaction. Patients do not choose to have BPD. That's an absolute fact, right? Is that no one chooses to have BPD. No one's like, yep, this sounds like a great idea. I've never had any of my clients ever say that. Recovery is possible and likely. So these are the facts. These are things that are true, right? Recovery is possible and likely. Very true. After 2 years, here's a great statistic, right? After 2 years, more than 50% of patients recover. And I like to always pause after that because I think our world is so fast, we don't allow ourselves to think about what that means. After 2 years, 50% of patients recover. After 10 years, here's another one, more than 80% recover. Think about that. Now, also, 88% of individuals diagnosed with BPD remain in recovery status. Now, in looking at that, right, what does recovery mean? Recovery means that you're able to have vocational stability, right? So you're able to maintain a job, you're able to stay in school, right? Also, you're able to have decent or stable relationships. Now, which means that they're not these violent ruptures in relationships. They're not these violent reactions to relationship ruptures. That's what we're talking about recovery. Because when we think about BPD, what is it? It's often impaired socioeconomic dysfunction, right? It's this great impairment in social functioning and interpersonal functioning. And I think in recognizing that these individuals can reach that stability, that 88% remain in recovery. How is that not a hopeful diagnosis? Because it is a good prognosis diagnosis. BPD is a good prognosis diagnosis, and that's another fact, right? Also, the diagnosis of BPD is often withheld from patients and families. That's absolutely true, but I don't believe that it should be. I only use talking about diagnosis to put it in a context of treatment, not in a context of self-definition. So what I tell, all of my clients, as well as, on my YouTube channel, I talk about that as well, that diagnosis is not used for self-definition. It is used to guide treatment. So we have too many people, I think, who say, oh, well, I'm BPD. Whoa. No, you're not. Because if you define yourself by BPD, how can we undo that if that's who you are? Because you're not. And I often pair it with cancer. So when individuals have cancer, they don't say, oh, I'm cancer. No, they don't, right? They say what? I have cancer. And that opens it to psychologically recognizing the treatability of it. You may have BPD, but you are not BPD. And making that distinction is so, so important. And over time, my clients, as we work together, I start to hear that. That's another metric of success too, where they start to say that, my BPD is different than I am BPD. So it's recognizing that separation from the diagnosis to the concept of self. And then lastly, kind of this last fact is that BPD is underdiagnosed, misunderstood, and over-stigmatized. And again, and I talked about that earlier, so I won't go back to that issue here, but that it is, that's the impetus for me doing what I do, is so that people can understand this is a treatable disorder, that it is something that can be managed, and it's something that people can recover from. So just, and, just a kind of a last part to sort of talking about it is that, in a nutshell, with everything that I talked about, what I hope people recognize is that BPD is a disorder of relationships. Because when you look at the 9 criteria, 7 of the 9 criteria relate to relationships. BPD is a disorder of relationships. So if we can recognize that it's a component of relationships, build skills in managing relationships with self and other, then we effectively treat this disorder, which we can do. So I just want to make sure that we have enough time for questions. I have other stuff. If we want to get into that, I always have a lot of stuff. But
please go. It's very interesting.
Oh, I can keep going. Okay, I could fill your whole day because I really enjoy talking about this. So so when we talk about BPD and we talk about those comorbid conditions, so 84.5% of BPD patients also have mood disorders, anxiety disorder, and substance use disorders. So when I work with folks who have substance disorders, the substance disorder, this goes back to that complex BPD issue, which is that we have to treat the substance abuse first. So because what's going to happen is if we're working with core content, if you have a maladaptive coping strategy that is alcohol or drugs, every time we hit core content, which brings up all of this negativity, brings up all this shame, doubt, fear, rage, frustration, things like that, how does that person go to cope? They go to substances. That's why the substance abuse has to be treated first. One of the great things about DBT and the brilliance of Linehan is that she recognized the value of mindfulness. Mindfulness is not meditation, right? We know that. It's about being present. And I think in part why she did this is so instead of getting lost in disassociation and getting lost in rage and these action urges, which are often maladaptive and destructive, is that if you slow down, reprocess, press pause, as I tell a lot of my clients, sometimes we just got to press pause. You may not like it. This isn't about liking it. This is about doing it differently. So it's pressing pause. Sometimes we got to take a deep breath. Sometimes they use a mindfulness strategy. Sometimes it's a piece of chocolate. Sometimes it's a little fuzzy or a key or a keychain or something like that, something hot, something cold, an ice cube, whatever it may be, that brings you center and focused. Then you can reprocess and determine your best course of action. If you want to engage in something that is self-destructive, all of my clients are adults, so they're all 18 and over. If you want to engage in something destructive, I can't, I'm not Superman. I can't come in and say, don't do that. If you're going to make the choice to do that, you're going to have the consequences of that. But all of my clients, and this is 100%, have always said, if I could engage in behavior that would increase the probability of positive outcome, I would do it. There's no guarantees, right? Because we're all adults and we know the reality is, right? It doesn't matter how nice you are. It doesn't mean the world is going to work out. It doesn't matter how mean you are. It doesn't mean that you're going to pay the consequences for that meanness. But it's about probabilities. If you can engage in behavior that increases the probability of positive outcome, why wouldn't you do it? And all of my clients agree with that. I've never had anybody say, I'm not going to do that. I'd rather just be totally self-destructive, which means everything will work out great. Because if that was true, why are you spending all your time and money coming to see me? So, I think we need to recognize that. So substance abuse, we have to treat substance abuse first. So again, it depends on what those comorbid conditions are as well. So there are 4 domains. If we just talk briefly, just kind of about like the 4 domains of BPD, right? These 4 domains is emotional, and think about it. So the components of BPD, when you think about the emotional, behavioral, interpersonal, and identity or self, these 4 components, they make up life. They make up BPD, right? Often individuals with BPD have emotional impairment. The emotional impairment drives the behavioral impairment. The behavioral impairment tends to impact interpersonal. And because BPD is about relationships, that interpersonal disruption tends to get internalized, so it disrupts the concepts of self. But what's interesting is if we can work on the emotional first, and then utilize adaptive behavioral strategies, then you can have better relationships, which all of my clients want better relationships, whether it's with themselves or others. But if you can have better relationships externally, then perhaps that can increase your concepts of self. Now, that doesn't mean that I encourage my clients to base their concepts of self externally, but many of my clients do. They base their concepts of self based upon how good their relationships are, but a lot of their relationships are in a downward spiral because they engage in behaviors that increase the probability of negative outcomes. Screaming, yelling, violence, self-harm, going to the emergency room, whatever it may be. And I'm not saying those are bad things. I'm just saying they increase the probability of relationship disruption. So if we can work on managing the emotion, as well as, I like to come from two sides, where the other side is managing that concept of self. If we can work on emotions and identity, behavior change and interpersonal relationships change. If BPD is a disorder of relationships and we can improve relationships with self and other, we're treating BPD. And BPD can and is a successfully treated disorder. So those four domains, just again real quick, it's emotional, behavioral, interpersonal, and self and identity. These four domains. So we have to look at it to, if you're thinking, geez, do I have BPD? Look at these four domains. Say, you know what? Do I have emotional disruption, right? Which is when your emotions get activated. Do you just engage in these urgent emotions, these urgent, destructive patterns? And what about your behaviors? Are your behaviors, do they increase the probability of negative outcome? What about interpersonal? Who's in your interpersonal circle? Are they positive folks or negative folks? Interestingly enough, everybody I know, whether you have a PD or not, they tend to fill their interpersonal circle with people who justify how they see themselves. If you see yourself as less than, you tend to populate your interpersonal circle with people that justify your belief that you're less than. One of the hardest things for anybody to do, BPD spectrum or not, is to recognize that someone in your interpersonal circle, and this could be mom, dad, brother, sister, cousin, is actually maladaptive, is actually negative. And those are hard choices. And sometimes you have to create distance. You don't have to always cut them out, but you have to create distance, from you to that person. And that's really hard. And that's not like just a realization, oh yeah, you know what? I'm going to create an emotional distance between me and my mom, right? Because my mom often, triggers me. Yeah, well, how do you do that? That's the component of therapy. That's about learning insight. That's about the recognition. Why is mom doing what she does? Maybe mom engages in this, that, or the other thing, or says these things because she's probably fulfilling her own needs or managing her own fear, whatever it is. So it's these complex components. So again, it's managing those interpersonal relationships and who is in our interpersonal circle. I think we all need to look at that. And if there are people that are destructive in your interpersonal circle, I think then we have to make a hard choice and say, how close emotionally am I going to allow myself to be to that person? Because I think that we have control over how emotionally connected or disconnected we are to others. And then lastly, so these 5 treatment areas. So there's often these 5 treatment areas that I look at with all my clients, which is aggression. So how aggressive is the individual whom I'm working with? And aggression isn't just towards an object of other. It's not just towards, something external. Aggression can also be towards the self as well. So we're looking at really 2 sides of aggression. We're also looking at suicidal ideation. So another book that I haven't proposed to my publisher yet, but I think about this all the time. And I think that a lot of us are like computer code, or computer code is a lot like us. And that we have these default patterns, and so CBT calls it like automatic thoughts, but this is more complex to that, because what it is it's default. We don't even think about it. We just do it. But it's the combination of thoughts, behaviors, and it becomes this intermix. So how do we break default? How do we unlearn habit? So one of the original theorists of psychology, William James, so he talked about habit. And he said, habit is created when you do anything 30 times. Think about that, right? if we're talking about that and we're talking about treatment and we're talking about creating maladaptive strategies and we have to do it 30 times, that's a lot of times. Does that necessarily build a habit? I don't know. William James seemed to think so, but it depends upon, I think, the complexity of the behavior. But in many of my clients, suicidal ideation is a default. It is that and that doesn't mean it's not serious. It's always serious, always needs to be assessed, always needs to be, seen as important, never blown off, anything like that. Just want to set that component, make sure that's clear. But it becomes automatic. It's that these people, so they reach this level, right? And once you reach this level, this kicks in, this default code. And the default code is, well, I might as well kill myself. Heck with it, I might as well kill myself. So the stress builds, I might as well kill myself. Sometimes folks' level is very low. So they incur immediate stress, which triggers core content, which triggers maladaptive beliefs, behaviors, and patterns. And then you end up with this idea, well, I might as well just kill myself, right? So it becomes this instinctive response. So with all of my clients, when we talk about suicidal ideation, and we talk about it all the time, is that, okay, so is this a default pattern, and what's the degree in which there's then going to be follow-up by behavioral engagement? Just thinking you're going to kill yourself doesn't kill yourself, right? It's plan, intent. So we also have to look at that as well. But is it a default belief? Because if it is, and you're working with me, we're going to cut that out real quick. And by saying that, I don't mean that it's easy, but I mean we're going to recognize the value or the safety that that person feels in that suicidal ideation, which a lot of times it's this sense of, I just can't take it anymore. I need some help. Someone needs to help me. I'm overwhelmed. That's different. Saying you're going to kill yourself is not perceived as, please help me. I'm struggling. It's perceived in two different ways, but I think folks with BPD have a difficulty managing that. The other, and the next treatment area is stress. How well do our clients manage stress? How well do people with BPD manage stress? Usually very poorly. And then next, about non-support. Do you have who in your interpersonal circle is supportive? Who in your interpersonal circle is supportive of treatment? Because what's going to happen is as you grow and develop going through treatment, you're going to change, which is going to change the patterns and the interaction and your role with others, which means other people are going to have to adapt to the change of how you live your life. Other people don't like to change, and that's where that stress comes in. We can look at it from alcoholism. A component of alcoholism is that, someone who is an alcoholic, they go in and they get treatment, right? And they start to use strategies. They're managing their alcoholism very well. Then they go to their family, let's say. So they go to their family, and their family's like, well, let's say that this person's name is Jim, right? And they're like, well, Jim's an alcoholic, but Jim isn't an alcoholic. He's not consuming alcohol anymore. He's using adaptive strategies, and he's managing himself. But let's say in the family, Jim is in that alcoholic role. What happens is that there becomes this implicit and indirect pressure for Jim to go back to that role. And it doesn't mean that the family, they said, oh, when Jim fails, we all feel better. But when Jim is in that role that we understand, we feel safer. So we have to look at what is that support system? Does that person have positive support? And they have to recognize as your role changes, you're going to have pressure to go back to those old maladaptive roles. So you have to manage that as well. So that's another treatment area. Another treatment is treatment rejection. And rejection overall is that what happens is over the course of time as you start to change, and these other four areas, aggression, suicidal ideation, stress, and interpersonal support or non-support, as you start to grow and develop, there's going to be pressure to leave therapy. All of my clients get it. They all get this implicit pressure from friends, loved ones, whoever it is, to leave therapy because they're like, why are you still going to this guy? I mean, right? You haven't been inpatient in 2 years. Why are you still going to this guy? Maybe they're taking advantage. But so then you get to see that. But what you're doing is you're solidifying. Sometimes you're in the maintenance stage. And sometimes some folks are like, you know what, I'm going to take a break. But that treatment rejection, there's initial fear of change. And fear is part of this process. It's part of this developmental process. So we have to embrace it, I think, as mental health providers. We have to look at, okay, I understand that you're afraid, to work on this stuff. Who isn't? I mean, yeah, I understand that. If someone came to me and said, you know what, all of your your strategies to manage stress, anxiety, your relationships and everything, they're really destructive and we're going to change them all. That would scare the heck out of anybody. So we have to recognize and I think be compassionate about that treatment rejection and recognize that that's on a spectrum too, and where that is for that individual, particularly as they develop strategies that are more adaptive and that they start to change. So those are all my stuff, and we got a little more time. If you have questions, I would love to answer any questions, or if you have anything else.
Well, you said you could talk all day long.
I can.
We could listen to you all day long.
Oh, very nice.
Both ways. Let me, maybe go back, not stop you, but go back to this comorbid disorders. You mentioned, but I'm interested in social phobia because you didn't mention it. Didn't hear it. And I think that there is also the case of comorbidity between social phobia and BPD. What it talks about it. So can you give us a little bit?
Yeah, and that social phobia would sort of fall under that anxiety component that is often comorbid.
Okay.
And I think that, but absolutely, I think that social phobia, particularly when we look at that fear of looking like a failure, which then triggers that one of those or several of those 4 domains of BPD. So it's that, if I don't do everything right, then I must be a complete failure, and other people will then see me as a complete failure. So what happens is that I think individuals then they don't try, and they become very fixated or stuck in place because of that social phobia. So I think if someone has social phobia, I think we have to deal with the BPD, because it's the BPD that's feeding that social phobia. And so in that case, what I like to do is, okay, what's that core content component that is driving that surface structure of social phobia, of social anxiety? And if we get to that, sometimes it's the sense of being abandoned, sometimes a sense of emptiness, a sense of invisibility. I had a client many years ago, and one of her intense core content areas was invisibility. But she liked to be invisible, but yet when she felt invisible by others, she would then self-harm. So it became kind of a balance. So if you look at that, whereas social phobia, I think she qualified because if she was out in public and she did anything wrong, or maybe stammered or used the wrong word, or her grammar was off or anything like that, she would quickly just attack herself, engage in self-attack, tear herself down. And then she wanted to be invisible, but then would self-harm because I'm invisible, right? And if it sounds confusing, it's because it was, and it is.
Okay, there are 2 questions. Thank you. There are 2 questions. I don't know if you can see it, or should I read them? Okay, so first question is, how can you tell if your BPD or BPD traits client is ready to leave the therapy?
If they're ready to leave, I always leave that up to the client. So some of the metrics that I look at, typically successful treatment is not one hour a week. That doesn't work. And the research supports that. Has to first start with 3 times a week. And then, now that 3 times doesn't have to be a full, therapeutic, 3 hours a week. Sometimes what I do with a lot of my clients, and sometimes it's an issue of funds as well, is that we'll have 1 therapy session, and then we have 2 what I call sort of adaptive sessions. Those adaptive sessions, sometimes they're just 20 minutes on the phone. And we're not talking about content per se, an exploration that we do in therapy, but we're talking about what adaptive strategies can you use? What kind of things are coming up? Don't forget to use if we're using opposite action, let's say, or if we're doing radical acceptance. Okay, so, don't forget to use, your radical acceptance. So they're reminders, they're encouragement sessions. So I think what happens is when they're ready to go, you see that they're using less of the 20 minutes. They start to not depend on therapy as much. They start to sort of have more of a sense of independence. You also see that you have less self-destructive behaviors, less maladaptive patterns. So I think when you start to see that, but I let my clients choose as well, is when they feel like they're ready to go, and they do. I mean, sometimes it's 4 years later, and they're like, you know what, I feel good. I just want to, wrap this up. And I always let my clients know, you're not going to hurt my feelings if you want to end treatment. I mean, that's okay with me.
Thank you. Another question was from Alicia. Oh, a little bit more about social phobia. How would you convince a patient with BPD and social phobia to participate in DBT or other group skills training? It's often a challenge for us in Poland. It's not a popular form of psychological help. Such patients often prefer only individual therapy.
Okay, so I'm not sure that I understood the question. So yeah,
So I understand that somebody has both BPD and social phobia, and it's difficult to persuade them to take part in some group sessions, in group training, for instance, DBT. So how to convince them to do so?
Okay, typically I think that DBT groups are great, particularly when they're skill building. I think that if the only treatment is group treatment, I think that's really difficult, because I think what happens is that you have a group of individuals, and they can't be a large group. You can't have 12 people along the BPD spectrum in a group, and you're hoping that everybody is going to, get insight. Remember, impaired insight, universal across all personality disorders, so that everybody's going to get, a degree of insight. It's just not going to happen. It's just going to be too chaotic. So I think that DBT should be like a skills group, and next year I'm hoping to do like an online skills group, which is, and not necessarily just DBT, but adaptive skills overall. But I think DBT skills are really important, but then that should also be adjunctive individual therapy as well, so that you can kind of get into it. But if you're talking about the social phobia component, if you think, okay, so it has to be more psychoeducational, which is that group should focus on radical acceptance. Everybody has, your radical acceptance worksheets, and then we're going to walk through it. So of course, you have to create a climate of acceptance, right? And you have to say, you know what? All of us in here are going to mess up. So there we go. We're all people, and it happens. Everybody messes up. I don't care who you are, right? I don't care if you're Einstein, right? Or you're Dan Fox, doesn't matter. Everybody messes up. And it's the acceptance of that. So I think we have to create, this idea of acceptance, and that diffuses some of the anxiety. And if everybody can say, okay, and then I like to go around, if it's like a social phobia or people are afraid of making mistakes, that, okay, let's go around and talk about a mistake that we made. Not that blew up our life, but what's a mistake that you made, right? How many of us have we mean to hold the door for somebody? I like to pride myself on being very polite. So, when I'm going out, I always kind of hold the door for a second, and I always look if someone's coming, And so let's say, right, I'm holding the door, but I accidentally, it slides out of my hands and, bumps into somebody. Am I a terrible person because of that? Of all the times that I've been polite, does that mean I'm, that now they've all just been negated? No. So I made a mistake. So how do you repair it? So that's just what I would do in the group. I would first of all normalize this sense that we all make mistakes, and then try to diffuse that sense of social anxiety and make that DBT group more skills-based as opposed to interpersonal and insight related. And I know that Linehan has a different approach to that, but that's just my approach.
Another one, how to encourage a young person with BPD to take part in family treatment when family is willing to do so?
Okay, so I think family treatment is really tricky, because I think we have to be careful about what's called the family crucible or the identified patient. Because a lot of times what the family structure may do is they may say, well, the reason why this family is not working is because of him or because of her or whatever. So that becomes the identified patient. That becomes what's called the family crucible. And that means that all of our problems are because of that person. That is absolutely positively not true. There's not one person that is completely destroying your family. It's a component, right? It's about patterns. It's about interaction patterns. And I think that family system needs to then work on itself. And everybody has to understand that it's all of us willing to make changes. We're not all coming in and saying, well, she needs to change. That I think is a recipe for destruction. But I think that if the individual recognizes, hey, you know what? There's stuff all of us need to work on. I think there's a greater degree of acceptance, as opposed to pointing at that person and saying, quit messing up our family. If you can get it straight, then we'll be this, magical, super great, family. I don't find that to be true.
Okay. Thank you, Daniel. Thank you for being
Okay.
with us today. I hope to see you one day in the future.
I hope so. I hope that you'll invite me to present in person. I would love to do it.
Oh God, we would love to. Okay, well,
Yeah.
once said, we will do it definitely. So,
Yeah,
sorry.
please put me on the list. That would be terrific. But thank you
Okay.
all for your time and attention, and I hope that this was helpful. So thank you.
It is helpful. It is
Thank
helpful.
you. And here you can see your book.
Yeah. Cool.
In October. But
Right,
it
well,
looks so
and I know that
nicely.
you have another speaker, but so thank you very much again, and I do appreciate your time. Thank you.
Thank you. Thank you. Once again, bye.
Take care. Bye bye.